To begin with our next session, let me call upon the panelists and the speaker, starting with Dr. Rajendra Prasad, Dr. Arvind Kumar Moria, Dr. Suven Bhattacharya, Dr. Vinod Kumar Arora, Dr. Satyanshu Mathur, and Dr. Anurag Badhani. Over to the panelists. Thank you.
Thank you very much. Hello everyone, and welcome to this session of current concept of AIOC Virtual 2021. This session is the cataract surgery, the complex cataract surgery management, and we have the speakers, very highly experienced speakers, and it's going to be purely a video presentation, and after each presentation we'll have a discussion of 2 to 3 minutes discussion. And our speakers, to start with, we have the first speaker is Dr. Arvind. Dr. Arvind has joined. Dr. Arvind?
Yes, sir.
Yeah. Dr. Arvind, yes. Okay, so our first speaker is our very dynamic and brilliant surgeon, Dr. Arvind Kumar Moria. Dr. Arvind is the professor of AIIMS, BB Nagar, Hyderabad. He's going to talk about approach to hard cataract with appropriate technique and settings. So over to you, Dr. Arvind, and you can share your...
Thank you so very much, sir. Everybody can see my presentation?
Yes, we can see.
Yeah. So I will be discussing on a terminal chop technique, that is a new nuclear fragmentation technique, especially for the harder cataract. It was introduced and invented by Dr. Rajendra Prasad, sir, and it is best suited for medium to hard grade of cataract, and it reduces surgical time and chances of complication. And this technique was first published in IGO in 2016, and we are practicing this technique since 2013, when Dr. Prasad first described the same in a conference. So the principle behind this technique, that it is a technique used to create two halves of the nucleus without making any horizontal excursion. This technique typically explores Griffith's theory of brittle fracture. It creates a shallow groove with the specially designed chopper terminator and keep the chopper in a lateral position. And with both the chopper and phaco probe, a splitting force at 90 degrees is generated. And this is propagated from the equator to center and equator on the other side. And this force is working along the brittle lines, and inside out dispersive mechanical forces are used to create the crack. So this is a small video. So a small crack is created. You see it's a very hard, big rock. This rock divides on the basis, so a crack is created. So we follow the Griffith's theory of brittle fracture. So in brief, first is the completion of capsular axis. Then a short superficial central trench of 1 into 1 into 1 mm size is created to hold and engage the phaco tip. Then the phaco settings are changed to high vacuum settings of 450 to 500 millimeter of Hg with 50 to 60% of power and 35 millimeter per minute of aspiration flow rate. Then the phaco tip is engaged at the distal end of the trench. Then the phaco probe is impaled, superficially keeping the tip directed towards the equator, parallel to the pupillary plane to achieve firm hold of the nucleus just within the equator. Then the equator is drawn within the capsulotomy edge, and under direct visualization, a wedge-shaped blunt olive tip chopper terminator is simply passed around the lens equator. Then the terminator is then simply dragged 1.5 to 2 millimeter through the open edge equator to create a small groove. And this dragging generates a tension and dispersive forces along the side of the groove, consonant to drag, pick, and rock excavation system, and initiates a full thickness nuclear crack. And this full thickness crack traverses automatically across the lens to the other end of the equator and divides the nucleus into two equal halves. So this is the spatial terminator chopper used in lateral position, and this is how it divides the nucleus into two heminuclei. So there are a few videos. Completion of rexes, main port entry, triplanar, side port, then the hydrodissection and delineation, coating of endothelia with HPMC. Now you can see this is the terminator chopper, grade 2 to 3 hard cataract. So it is holed, and now it is dragged outside the rexis margin, and now it's divided into two heminuclei and further division. So you can see it's just superficial impalement of the nucleus. It's not deep. Another video. Completion of rexis in the side port. And there is no chance of any trauma because the tip is blunt, as you can see in this video. Superficial, it is for holding, and then rest is with the help of the terminator chopper. Another video. Initiation of the capsular axis. It's a deep-seated eyeball and the patient is uncooperative. So this technique can be done in these kind of patients also. You can see this is a terminator chopper in a deep-seated eyeball, grade 2 to 3 hard nucleus. It is holed, it's out of the capsular axis margin and divided into two heminuclei quite easily, without any problem. And again, holding superficially, then dividing into further heminuclei. This is entry. This is the third video. You can see the golden ring. So it is sold superficially and with a very easy stroke is divided into two pieces, then further smaller pieces. So it's a very easy technique. So we have modified this technique. We are keeping the phaco-parameters in moderate range, and instead of using a spatial chopper terminator, simple chopper or dialer can also be used, and we have operated on all grades of cataract. And we have a prospective case sheet analysis from October 2016 to May 2021, and we have done more than 3,000 cases, and we have detailed data of 1156 cases, and nuclear grade was between 2 to 5, and they all were operated by a single surgeon. So these were the demographies and the other things. So the rate of complication is similar to any other technique. These were the results. The average total ultrasonic time was 1 minute 34 seconds, average phaco time 49 seconds, average torsional time 91 seconds, and average bottle height of 80 centimeters. So how it is different with other technique? Some say it is a modification of horizontal chop. No, it's a separate technique. It's a very different technique. In terminal chop, the instruments tip move away from each other at the equator, and superficial impaled phaco probe is there in this technique. Whereas in the horizontal chop, the instrument tip move towards each other in horizontal plane at the equator, and the phaco probe is deep and it's towards the optic disc. In the vertical chop, the instrument tip moves toward each other in vertical plane, and the chopper is the direction of the sharp chopper is towards the optic nerve. In terminal chop, it propagates the initial crack into a full thickness fracture in low compressive stress, whereas in horizontal chop, it creates a stressful compressive force, and in vertical chop, there is a shearing type of force is generated. And we have this study published also in IGO. And we have done a clinical trial on a comparison between the stop and chop technique in the direct chop versus the terminal chop, and it was presented in the previous ESCRS. So there are a lot of myth about this technique. Some say that it is a blind procedure, but we do the everything, every step is done under direct visualization only. And the chances of PCR are comparable. And the chances of endothelial cell loss and post-op edema, they are comparable or lesser. So we did this clinical trial between 3 types of chopping technique. So science can't be a myth or hearsay, it will always be a reality. And these were the results. So in every type of technique, there were more than 100 cases. And in the demography and the endothelial cell loss, the CCT change and the intra complications, there were no significant p-value difference in all the 3 techniques. Whereas when comparing the cumulative dissipation of energy and the total phaco time, there was a significant p-value of more than 0.005. So it has an advantage in terms of cumulative dissipation of energy and total phaco time. Thank you.
It's a very nice
presentation, and you have given such a beautiful data, and it's really a pleasure to see your work on this technique. And any question from Dr. Arvind, Dr. Vinod?
Yeah, Dr. Arvind, what is the ideal size in this technique of capsular axis?
It should be 5.25 to 5.5, sir.
Any reason for keeping it low? If we keep it low or if we keep it higher, any problem with that?
Because when we are dealing with the softer cataract, means the grade 2 to 3, there is no problem. But when we are dealing with the grade 4 and the grade 5 nucleuses, then we need a proper axis size, because we need that superficial empanelment of the nucleus at the equator, and it must come out through that capsular axis margin, because everything we need to done under direct visualization only.
Yeah. So bigger axis is preferably better if you want to start with this procedure, or for the beginners.
Yeah, for the beginners.
Yes.
In any case, like if you are dealing with the hard cataract, in any case, you have to make a little larger axis.
Definitely.
Whichever technique you use. If you have a larger axis, your manipulation becomes much easier. And put now, especially in terminal chop, like then your terminator, putting the terminator around the equator of the nucleus becomes much easier if you have a little larger axis. But as Arvind said, like if you have a little on the grade 2, grade 3, grade 4 kind of nucleus, a little softer also, then you don't need such a big axis. You can very well do this technique with a 5.25 or 5.5 millimeter axis also. So beautifully presented, Dr. Arvind, and now we'll
Thank you, sir.
Next presentation is by Dr. Suven Bhattacharya. You all know that Dr. Suven is an international figure in ophthalmic surgeons field, and he is famous for his new device, that is VHAX, and we all are using that VHAX device now at present. And he is going to talk about the small pupil management along with the hard cataract and managing with the new devices. So over to you, Dr. Suven Bhattacharya.
Yep. Thank you, Dr. Rajendra Prasad. A wonderful course as always, and I must congratulate you on the Terminator, though I don't personally use it, but I have seen I have very rich praise for this for the people who use it. I'm more comfortable keeping my hard nucleus inside the bag. So let's see how we deal with this on this topic. Small pupil and hard cataracts managing with new devices. I do have a financial interest in the BHEX pupil expander, and I acknowledge the contribution of Dr. Deepak Megur for the videos that I have borrowed. So now when we look at small pupil and hard cataract, I think it's most important for each one of us to know our comfort zone. pupil size vis-a-vis the hardness. There is always each one of us, we have our own sweet spots. So I would recommend that you use a pupil device, any device, when you have a hard cataract in a small pupil, because the central corneal endothelial damage is going to be much more in a hard cataract. Often these hard cataracts are associated with comorbidities like pseudoexfoliation and subluxation. They also, if there is pseudoexfoliation, there's likely to be a rigid pupil, and intraoperative meiosis may be difficult to handle with more attended complications. So you must. Now, if you choose not to use a device, like many surgeons are very fond of not using a device, I would like to ask you that if you have a hard cataract and a non-dilating 4mm pupil, and a very skilled surgeon is operating, what would you prefer? The surgeon use only skill and no device, or the surgeon use pupil device and skill? I guess since availability and cost both are not an issue, it's better to be safe than sorry. So if you're not using a device, I think it's better to be prepared for intraop meiosis, and earlier the call, easier the going. Before, there are different stages where you would find different stages, different intensity of difficulty before the capsular access, after the capsular access, and before nucleus disassembly, and during the nucleus disassembly. So it's best to do it as early as possible. So let's talk about the BX pupil expander. It's a 75 micron device which has a circumcircle of 7mm, 6 notches, 6 flanges, all in a single plane. It comes in a preloaded housing, transparent housing. You just need to advance it from the housing into the eye and place it on the iris, and then tuck alternate flanges under the pupil margin. And you have a wonderfully dilated hexagonal pupil, which a 5.5mm pupil. It's a univalent planar device, so the iris bends, but the device remains in the same plane. Removal has never been easier. Through the main incision, it's always a cakewalk. And the best thing is you can even remove it through a 1mm side port incision. So the BX, as I said, is as thin as a human hair, 75 microns. That is the thinnest device available. And that's the reason why it can work out through a 1mm side port. So that's the packaging and the device, preloaded device. For all new users, we would recommend using the get a pack of 5, and the BX 23 gauge forceps is a necessary accessory, because that is what is useful in manipulations. Anything else used will not really give you the desired results, and you may be unhappy. So this is a comprehensive solution for small pupil. It's a simple design, user-friendly, tissue-safe, and affordable. And of course, it's a no-brainer. So how big do you want the pupil to be? Now, that's a big question, especially in hard cataracts. Often it's with iris hooks or other devices, we want them to be pretty big, so that, that is just is a psychological advantage. But if you ask yourself, aren't we all skilled to perform phaco through a 5.5mm pupil, which will not get smaller? And that assurance is given by BX. And I would recommend that even if you're using iris hooks, not to keep your pupil larger than 5.5. That is not good for the health of the pupillary margin. You may have defects, and which may cause a lot of glare in the post-op period. So you need to differentiate the elastic and the rigid pupil. The elastic, any pupil expander would work. It's like a rubber band, whereas the non-elastic one is like a string. So you need to tear it or break it. So you need a strong and bulky pupil expander, or you could use a Coughlin hook. Pair of Coughlin hooks. So let's see the steps in the BX. So you need to inject viscoelastic under the pupil margin and lift off the pupil margin a little bit, and take the device and place it on the iris, and then start tucking each flange. Alternate flanges are tucked, and that's the first flange which goes under the pupil margin. These tabs with holes are more for identification and easy manipulation. Otherwise, these holes are not to be used for inserting any manipulator through them. And there goes the last flange under the pupil margin, and you have a wonderful hexagonal pupil. So it's a very simple, user-friendly device, does not require a learning curve, intuitive. Now let's see a hard cataract. Anything less than 4mm and a rigid pupil, I would always recommend that you stretch. For any device, even for iris hooks, that gives you a nice round pupil in the post-op period. So this is a pretty hard cataract. For those who think that you require a larger pupil size for a hard cataract, well, you see, this is a pretty hard cataract. All you need to do is chop it into as many small fragments as you can. What method of chopping you use? You could use Dr. Rajendra Prasad's the terminal chop, or the direct chop, or even a stop and chop if you're comfortable doing that. But as long as you chop it into small fragments, 5.5 is a very good size for any hardness of cataract. And the BHEX, like I said, works out very easily through the incision. And it's good enough for any maneuver of yours. Now, this is a shallow anterior chamber. There again, the BHEX has a huge role because of the thin profile that it has. So it's a 75 micron device, whereas anything like a Mulligan ring is 0.9 millimeters. And that, when it's placed in the mid-peripheral anterior chamber, the corners, that could be a touch and go in a shallow anterior chamber. So because the mid-peripheral AC is shallower than the central anterior chamber. So like you see over here, it's a shallow anterior chamber, yet it's so easy to tuck these flanges under the pupil margin under direct visualization so that you have no issues of endothelial touch or damaging the capsule. If you're comfortable doing your capsular access and then the phaco, and in this case, there was slight zonular dialysis, so CTR also could be used very comfortably, and of course, IOL placement. And removal of the BHEX is very easy as usual. So, sorry, let's go back. Yep, so this is a case where we have intraoperative myosis, and let's see how the BHEX helps the situation. So now this is a pretty hard cataract. So the pupil has come down. I still have a heminucleus of hard cataract there. At this stage, I take a call that I would probably require to use a device. So this pupil will not dilate with adrenaline. So you use BHEX, the viscoelastic under the pupil margin over the capsular rim and lift off that pupillary margin. And then now the advantage over here is with the BHEX is you can tuck those flanges without engaging the capsular rhexis margin because you're doing it under direct visualization. And even if you do engage, you can retract and go back, which you can't do with a remote held device like a Mulligan ring or others. So you have instant confirmation that you have not engaged the capsular rhexis margin when as soon as you're tucking the device and you push it to the periphery. So once you have that 5.5 pupil, you are in a comfort zone and you can deal with any hardness of cataract or any complication that you might have had. So now, like I said, when you have an intraoperative myosis, a device like a Mulligan ring, when you are watching to the top view, the scrolls or the pockets are on the side. So you cannot see the gap very well. So it's very difficult to align it to the pupil margin. So there is every chance that you will engage the capsular rhexis margin, and that would be a disaster. Whereas in the BHEX, the gaps in the notches are clearly visible from a top view, and it engages the pupil margin with certainty. So let's see this video from Dr. Deepak Magur. So capsular rhexis is done, nucleus rotated a bit, and he starts the phaco, and this is a hard cataract. And at this point, he decides, no, it will not be possible to do a phaco without a device. So he goes ahead, injects viscoelastic under the pupil margin. Like I said, lift off that pupillary margin and then tuck those flanges with instant confirmation that you have not engaged the capsular rhexis margin. And then you have your comfort zone. The BHEX is the only device, only pupil expander, which can be removed through a tiny 1 millimeter side port incision. And that is a huge plus when you're dealing with iris prolapse and IFS. As we know that IFS, the iris prolapse would be from the main port, side port. So any which port which allows you a little bit of comfort, you could remove that device. And even when the anterior chamber is shallow, that is a huge blessing. If you're interested in reading more about the BHEX pupil expander and the tips and tricks, I would invite you to download this document. It's a PDF, and it has video links running alongside the text, and you need to click on the link to reach the exact scene. You could download it from the website. The page is BHEX pupil expander, and the subpage is ophthalmic surgeon. You could read my 10 tips on phacoemulsification in small pupil at eophta.com. Thank you very much for your kind attention, and thank you, Dr. Rajendra Prasad, again for this invitation. Sorry, let me stop. What happened?
Unmute yourself.
Yeah, I can unmute.
Dr. Rajendra, unmute yourself.
Yeah. Thank you, Dr. Suven, for the excellent video presentation and your device BHEX, which is now, I think, is the choice of pupil expander at present all over the world. And people especially looking for BHEX only instead of Mulligan, because I use both Malugen, I really find very difficult. The implantation as well as the extraction, removal of the Malugen ring is not very easy. On the other hand, the VHEX is very simple, and putting it in and taking it out is so easy. Like, it's very comfortable.
Thank you.
And all the advantages with VHEX, and I think we all should use it. And excellent video presentation, Dr. Suven, really good. Dr. Vinod and Dr. Arvind, any question to Dr. Suven?
There's one question from Dr. Kiranji. He wanted to know if whether the oval pupil is more helpful in doing hard cataract. It will give you more choice to see the end and other things.
I think the question was directed to Dr. Arvind Moria and Dr. Rajendra Prasad right in the beginning, where he wanted to know whether the terminal chop, for the terminal chop, the oval rexus would be relevant. So maybe Dr. RP or Dr. Moria can answer, because they are using terminal chop.
Yeah. The oval rexus, we have been working on it, and I spoke to Dr. Kiranjit earlier also, and I'm working on this, and we are, Dr. Arvind and myself, we are getting ready with a publication also on oval rexus with terminal chop, and Dr. Kiranjit is going to be part of that also, and it's in the process. And the second important point which I wanted to bring out was, like Dr. Suven said when Dr. Arvind was presenting, like in terminal chop, you bring the nucleus out. No, not at all. So this is the misconception. Actually, we do not bring the nucleus out at all. Nucleus is always within the capsular bag. It's only when you're holding the nucleus within the equator, you're just slightly drawing it. You're drawing the nuclear edge to see the edge of the nucleus within the capsular bag. It's never out of the capsular bag. And this drawing is just to hook the equator of the nucleus with the terminator, so that you get a crack at the equator itself. We never bring out the nucleus out of the capsule. This is absolutely misconception. So nucleus is always within the capsular bag, and it's the simplest way to crack the nucleus. And I think because to use horizontal chop or to use the vertical chop, you need a lot of experience, because you need a lot of practice, because I started long back, and it took me almost 10 years to learn it properly. And this terminal chop, now I come across just first year resident. He comes to me, says, sir, it's so simple to us using this technique. It's really simple. You get a complete crack. So that is what I just wanted to put in on. And the oval rexus would definitely help us, because if hooking the nucleus, if you have oval rexus, go along the longer side of the rexus and hook the nucleus. So it becomes still easier. So we are working on it. It's beautiful to have the oval rexus with the terminal chop technique.
I think you're just lifting the pole inside the bag only.
Yes.
You're lifting one pole that is inside the bag only.
Yeah, without damaging that rexus margin.
Yeah, without damaging the rexus. It's within the capsular bag only.
Yeah.
Yeah. Thank you, Suven, for the
thank you
presentation. Always pleasure to see your videos and your presentation, and thank you very much.
Thank you.
So now we have the next speaker is none other than Dr. Vinod Arora. Dr. Vinod Arora is the chairman of Wave LASIK Center at Dehradun. He is one of the very popular eye surgeon, and he is the one who's actually holding the Eyelight group of ophthalmologists, and which is one of the group which is liked by most of the elites in the ophthalmology. And Dr. Vinod is an excellent surgeon. He's going to talk about the soft cataract and supracapsular phaco. I think, right? Dr. The slight changes there in his topic. So he's going to talk about Dr. Vinod.
Are my slides visible?
Yes, sir.
Yeah, it's visible.
Thank you. So basically, once we get a soft cataract, we think it's going to be very easy. And especially for the beginners, they think it's just a lollipop. We can have it. And but soft may look cool, may look easy, but sometimes it causes a lot of problems. It may be even tougher than to deal with a hard cataract. In hard cataract, you know what is there. But in soft cataract, you are not sure what you are going to get it. The problem is that soft may have a lot of challenges, a lot of problems. It may be difficult to rotate. They may be difficult to hold by phaco tape. It's not going to occlude. Then it's difficult to divide by a chopper. Then there are increased chances of PCR. That's a very big problem with softer cataracts. So there have been several techniques devised for dealing with the soft cataracts. It may be irrigation aspiration. We can do tilt and tumbling. We can do phaco flip. We can do soft chop. We can do phaco chip and flip technique. Then divide and conquer in some little harder cataracts, and supracapsular phaco. That means we bring the nucleus out of bag and then we do the phaco. So depending on condition and type of nucleus you got, you can choose the technique. So what is the basic is there, we should have a good hydrodissection and it should be done on multiple sites. Then in visco flip, we do a visco dissection. I'll come to that. And soft nuclear material is pushed in toto that comes in the anterior chamber. Then it's very easy to phaco and is rather aspirated because it's a very, very soft cataract. So normally we keep the lower power setting. The power should be low, the flow should be low, and the aspiration should be kept to a minimal of required, whatever's there. And it can also be taken out in epinucleus mode. If you've got phaco machine and got epinucleus mode, that means your phaco energy should be around 0 to 20% with a fair amount of vacuum, around 150 to 200 millimeter of mercury. Then aspiration flow rate should be around 20 to 25. It's then become very easy. You can just take in epinucleus mode also. This is a lens salute technique. We are trying to make a capsular axis, and the size of capsular axis may be 5 to 5.25 millimeter. Well-centered some collision axis is made. Hydrodissection from multiple sites. We do hydrodissection from multiple sites and then slightly tilt the nucleus. That is done with the hydro procedure only. So Dr. Kikemita called as lens salute and he's very fond of it. So it becomes much easier. Your posterior capsular is far away. This lens is pushing posterior capsule backward and it becomes easier to manipulate the things. Depending on the type of nucleus, you can directly impale it, or if you require, you can chop it even. The things become much easier and you don't have to go inside. So it's a little on the anterior chamber since the cataract is very, very soft. So we are not worried about the phaco energy we are using minimum. Vacuum has to be a little higher side. This all fragments, they are maintaining your posterior capsular back. And it's become very easy to do the phaco. Then comes the visco flip. Is the second technique. It's almost similar. We do hydro procedure, that's hydrodissection. And if the nucleus is not coming out because of the hydro procedure, sometimes it's too soft to come out by anything. Even you try to hydroprolapse, it's not coming. But we have to do a meticulous hydro procedure there. Now we do the visco dissection. We put the visco behind this visco causes whole thing to come out in the anterior chamber. It just pops out. And our posterior capsule goes back. And we can easily either aspirate it or do the phaco aspiration. So visco is acting as a cushion behind. So everything has come out in total. And since it's a very soft, hardly requires, just phaco aspiration is sufficient. And the rest of the procedure, we know, irrigation aspiration, almost same what we do in other patients or other cases. It's similar. Your challenge is over by now. Then coming to the posterior polar cataract, we have got one talk for this. It's the almost same technique. We do the visco dissection in the plane of hydrodissection. And last piece is taken out by visco dissection only. So this is a case referred to us. Patient has nucleus drop in one eye. They are in other patient, other hospital, and we are going to do the second eye. So we are a little careful because the patient has nucleus drop in one eye. Access is done. And instead of hydrodissection, we do visco expression. It's called visco dissection. The advantage is that it doesn't cause hydrostatic pressure there. And rather we do hydrodelineation, I should say. And we are not using hydro at all. We are using it visco for that. It may be diluted visco or methyl cellulose, quite good. And the nucleus comes out, leaving the posterior capsule and cortex there. Now it can be easily taken out. And phaco become much easier. We have got a lot of safety margin there. And now we are left with cortical layer. Nucleus is out there. So our major worry is already gone. Now we do the visco dissection of this part. We use the OVD to separate the capsular bag and cortical tissue. We are not using hydro here. The advantage is that the visco pushes the things forward but it doesn't got pressure much on the posterior surface. And again, if there is a hole or something, it will keep on covering it. So cortical tissue is taken care of. And now we are left with a last piece, you can say. If you are pretty sure that there is a hole, we can use a viscoat or any things. Otherwise, methyl cellulose is quite good. I think if you were pretty sure, then it's better to use a viscoat for this, separating this thing. And we are trying to take as much as cortex possible without disturbing the posterior pole. And then the routine IOL implantation is done. So visco makes the every step very, very safe, and it keeps on cushion. If somehow, even there is a PCR also, it keeps the chamber stable there, and PCR doesn't extend. And I've seen that it does not causes as much pressure as we find with the hydrostatic pressure there. Visco gently softens the things. So in each case, we have to treat with or not merit. We have to first plan what we are going to do. We have to see the density of cataract, and the key of success is be prepared. If we know type of cataract is there, what is the density of cataract there, what are the complications that may be there. If we are ready, then every case become much, much easier. Thank you. Thank you very much.
Sir,
Thank
which
you, Dr.
viscoelastic?
Vinod, for the excellent presentation. And you have very rightly said, like soft cataracts are not that easy when what we think, because if you look at the literature, many times most of the complications take place in the soft cataract only, because we take it easy, and many times separating the soft cataract from the capsular bag becomes very difficult. Many times, because you start eating of the soft cataract, you get into the problem of Swiss wire phenomena or cheese wire phenomena. So you are basically left with the plate underneath, which normally gets stuck to the posterior capsule. Taking out that plate becomes very difficult. Many times you just hit the posterior capsule and you get into the problem with the PCR and other complications. So soft cataract should not be taken very easily, and Dr. Vinod has very rightly shown many techniques to deal with the soft cataract. And visco flip and visco dissection is one of the very simple and very good technique, because if you are able to separate the whole soft cataract from the capsular bag, then it's just the aspiration. It's only the separation. So take your time to separate the whole complex of the soft cataract away from the capsular bag. So that is the best idea. Dr. Suren, you would like to comment something on this?
Like I said, like you said, yes, soft cataracts are always difficult, because it's like when you have a phaco probe in your hand and you're actually, the more experience you gain, the more likely you are to have a rent in a soft cataract, because you get used to more faster parameters, and you kind of using a higher power, higher vacuum. So it's more often like a hot knife through butter. So that is why we need to be, as we gain experience, we need to kind of come down on the gear and the accelerator. So when we are dealing with soft cataracts, yes, I do agree with that. The chances are, and most of us have burnt our fingers. We've had our complications with soft cataracts only. And even in hard cataracts, we have the complications at the IA stage.
Yeah. Dr. Arvind, you would like to comment on this?
Sir, which viscoelastic you prefer for hydrodissection? Is the cohesive or the dispersive?
Yes, the methyl cellulose is the best. I think if you feel initially can use a diluted one, that's much better.
Okay. Further diluted. Okay.
Yeah, I think for the dissection, you have to use dispersive only. You cannot use adaptive or cohesive visco, because that would
for the
get
last piece,
really
we can
injured.
for the last piece effect there, viscose is much better there.
Yeah.
Because it seals the hole also.
Yeah. Well, for the dissection, you have to use dispersive visco only, so that you get a smooth separation of the whole complex from the capsule.
Whole concept is in layer wise. That's the whole concept.
Yeah, that is the best part. That is the best way. Under low parameters.
Yes.
Yeah. Thank you. Thank you, Dr. Vinod. And now next is my presentation. Dr. Satanshu hasn't joined yet, so I'll be taking up the next presentation. And
Dr. Rajendra is one of the best eye surgeon known. And in fact, he's called the Terminator because he invented the Terminator chop. And this has become so popular, and managing hard cataract becomes so easy. I think he has a lot of awards to his credit, and in a lot of innovator awards also. So over to you, Dr. Rajendra, for this beautiful technique.
Thank you, Dr. Vinod, for the nice introduction. And I'll share my screen. And so today I'm going to talk about yet another new technique, that is saving needle microcapsulotomy, a new technique to avoid Argentinian flag sign in introducing mature white cataract. So we have no financial interest in the subject matter of this presentation. So as you know that Argentinian flag sign is a self-propagating radial extension of the anterior capsular tear, which typically arises instantly after an initial prick with a sharp hypodermic needle or the sharp rhexis forceps. The moment you try to open up the anterior capsule with the needle or with the sharp rhexis forceps, the tear which is created by these two devices opens up and extend to the periphery and convert into the Argentinian flag sign. This phenomena was first described and reported by Daniel Perrone in year 2000. And Daniel Perrone actually described it to be the sequelae of raised interlenticular pressure. This was the physical principle he proposed, that it's the raised interlenticular pressure which opens up the capsule and extend to the periphery in the form of the Argentinian flag sign. Later on, the posterior to anterior compartment system was proposed by some other author, and but the concentration was on the raised interlenticular pressure only. So based on this theory, lots of newer innovations and new techniques developed to neutralize the raised interlenticular pressure. You can see here this precautionary, precision pulse capsulotomy, punchoraxis, two-stage capsuloraxis, resilient technique, femtosecond laser-assisted opening of the creation of the raxis in intumescent cataract. So all these techniques were described, and including these small needle aspiration technique. Now, we all know that this small needle aspiration technique involves pricking the anterior capsule with a sharp 26 or 30 gauge hypodermic needle, then followed by simultaneous aspiration of the liquid lens matter to decompress the thread. But what happens actually? The moment you prick the anterior capsule, before you try to aspirate anything from the capsular bag, the capsular tears start extending. So you can see here in this video, because the moment you try to prick for the aspiration, the tear which is created with this tip of the needle starts extending to the periphery, and it converts into the Argentinian flag sign. So what literature says, we went through all literature, and literature says that it is the raised interlenticular pressure which is the basic cause for the extension of the capsular tear to the periphery. And the incidence have been reported around 3.85 to 28.3%. And what is important in the literature, what we have seen is almost 7 to 24% of the tear which extend to the periphery extend into the posterior capsule and transform into the posterior capsular tear. So which could result in a serious complication in the form of vitreous loss, lens material drop, or the capsular support loss. So this is what happens. So the anterior capsular tear should not be taken very easy, because it can convert to the posterior capsular tear and you may get into this kind of problem. So the question arises at this stage, why, despite many innovative techniques to neutralize the raised interlenticular pressure, the problem of graded extension of the capsular tear continues to be a challenge in intumescent white cataract? Why? It means it's not only the raised interlenticular pressure which is the reason for the extension of the capsular tear. There has to be some other factor responsible which assists the raised interlenticular pressure to propagate the splitting of the capsular tear after the initial prick. So we actually did an extensive retrospective examination of the surgical videos where Argentinian flag sign was noted. And what we discovered, so these were the factors which were not known till now. So what we have discovered is, first important thing, in reality, it's not the raised interlenticular pressure, the only factor responsible for the extension of the tear. We found that it is the configuration of the initial prick which is created to open up the anterior capsule by the sharp tip hypodermic needle or the rexis forceps or the cystostom. When you open up to start the capsular rexis or for the interlenticular fluid aspiration, when you open up the anterior capsule, that is the problem. The moment you open, the tear start extending. So it is the configuration of the anterior capsular puncture which is the most important responsibility. If you look at the video here, puncturing the anterior capsule with ultra-sharp beveled hypodermic needle, it creates a small linear cut. So you can see here, because if you enter with this, you create a linear cut. And when you use the capsular rexis forceps, we normally tear the capsule first. We tear to raise the flap. So that tear with the capsular rexis forceps, as well as this linear cut produced by the 26 gauge needle or 27 gauge needle, is the reason. So this tear, actually what happens, you have a raised interlenticular pressure, and there would be a certain volcanic eruption of the interlenticular fluid also. So these factors triggers a disruptive force along the edges of this linear cut, which we have already produced. And what happens, this linear cut easily opens up and is split along its open edges and rapidly radialized to the periphery and results into the Argentinian flag sign. So you have this split or created on the anterior capsule, which opens up because of the high interlenticular pressure. So this is the reason, like this is configuration of the initial prick, which is the most important. The second important point which we have discovered during the examination of the videos, we found that tear always extends along the radial to the initial cut. It never extends perpendicular to the cut. So it means these open edges of the radial cut is the reason, because if it were not this, then it would have extended perpendicularly also, but it never extended perpendicularly. It always extends along the linear cut of the initial prick. So henceforth, we came up with an hypothesis that if we were able to manually create an opening in the interior capsule, which had a round and regular configuration, like a capsulotomy in true sense, instead of a linear cut, we may provide resistance against the forward thrust of interlenticular pressure, thus prevent Argentinian plaque sign. So we all know that if we have a round opening, that would have a much better resistance. So for this, we developed and designed a capsulotome, which is called as a saving needle capsulotome. This has a smooth, round, pointed tip, similar to saving needle system. So you can see here, this is the saving needle. The similar tip we have created for this, unlike the sharp and beveled tip of the hypodermic needle. So when this device punctures the capsule, it makes a hole of this kind, unlike the linear cut produced by the sharp hypodermic needle. So round pointed edge, why it is important? Because the round pointed tip of the saving needle microcapsulotome, when punctured the anterior capsule, it creates a round configuration without any discontinuity. So you can see here, this is a saving needle, which is puncturing the paper, and you can see that it creates a round hole. But if you puncture the capsule with the needle, it creates a cut. So it's a linear cut. So this is the problem. So round hole microcapsulotomy acts like a mini capsule. It has a much better resistance against these disruptive forces because it's round and circular. It doesn't have any open edge, so it doesn't open up easily. So you can see here in this video, like the microcapsulotomy, when you make a microcapsulotomy, because you're making a round hole on the anterior capsule. Now this round one, the moment you create the round hole, the fluid will start egressing out from the capsular bag. Now this fluid comes out from the hole which we have created on the anterior capsule. This egress of the fluid will decompress the bag. Now decompression, we can enhance the decompression by tapping and by doing a milking technique, so that you press the nucleus or periphery and bring the fluid at the center and evacuate it from that hole. So this hole egresses out the fluid and decompresses the bag. Once your bag is decompressed, then you can very easily start the capsular axis without any risk of extension. These are some of the videos. So you can see the first video. I'm showing you how it makes, because this is an immature cataract, nothing to do with the intumescent cataract. But when you prick the capsule with this device, you can see here. Now see the hole. So it has created a beautiful small hole at the center. So this device creates a hole. It does not cut the capsule. Now in the second video, you can see here, when you puncture, it creates a hole. The moment you create a hole, the fluid will start egressing out of the capsular bag, and the capsular bag gets decompressed. Similarly, the third video you can see here, the moment you break it, this is the animation, and it creates a hole, and the fluid will start egressing out of the capsular bag. We generally need a single microcapsulotomy to decompress the bag. Single is enough, most of it. But sometimes you must have seen these intumescent cataracts have a multiple fluid pockets. That is not fully immature cataract. They have a multiple fluid pockets. So in these cases, we do multiple capsulotomies, multiple microcapsulotomies. But only important thing is these multiple microcapsulotomy should be done within 4.5 millimeter of the diameter. You should not go beyond 4.5 millimeter, because then since you have to make a capsular axis of 5 or 5.5 millimeter, the axis should go out of these microcapsulotomy. So you can make multiple capsulotomies to completely decompress the bag. You can watch this video. This is a absolutely intumescent cataract, swollen, white. So most important point is you have to stain the anterior capsule so that visualization is better, and then pressurize the anterior chamber. After pressurizing, then use your microcapsular tone to prick the anterior capsule. So you can see like we have pricked the anterior capsule. It has made a small beautiful hole. This is the second video. Again, like you have made a hole and the fluid has egressed out. And now, and once you have egressed the fluid out, pressurize the anterior chamber, flatten the anterior capsule, and then you can start the capsular axis. You have to tear that hole now. I'm tearing that hole, making a tear from that hole, tear it, and raise a flap, and then you can start the capsular axis. And the capsular axis, you can very simply and without any risk, you can complete the capsular axis. So to conclude, in intumescent white cataracts, it is primarily the linear cut configuration of the initial prick made by the sharp hypodermic needle on the anterior capsule, which has the potential to spontaneously extend along its open edges, aided by the raised interlenticular pressure leading to Argentinian flag sign. The technique of saving needle microcapsulotomy creates an opening in the anterior capsule, which has a round regular configuration, like a capsulotomy in the true sense, that provides resistance against the disruptive force triggered by the high interlenticular pressure, thus prevent the Argentinian flag sign. The simple yet very highly effective novel tool, saving needle microcapsulotomy, creates a single or multiple microcapsulotomy to adequately decompress the bag prior to initiation of the capsular axis. Initial decompression of the capsular bag facilitates safe and controlled creation of the capsular axis of desired size with higher level of efficiency and safety. Thank you very much.
Excellent.
Yeah, I would like to make a comment over here. Wonderful. I must congratulate you, Dr. RP, for thinking about this. In fact, if you look at an analogy, you will see that there is a magic trick in which a balloon is pierced by something like a knitting needle, and or this kind of the wool knitting needle, and that's a round needle again. It's a round cross-section needle. So I think this makes a lot of sense, and I guess I'll be trying that in my next case.
Yeah. The only important point is, which I want to stress here, is because you have to have the what do you call it, tilted tip, right? The tip has to go vertically.
Vertical.
And
yes.
I've done one of the case with the parallel. I went parallel also with the saving needle, but parallel is not the ideal way to do it. You have to have the vertically, like the tip has to go vertically. Then it makes a proper hole in the capsule. So there is no risk of extension of the tear and making a tear. So you have to go vertically. That is important. And second important point is the tip has to be very sharp. The tip should not be blunt. See, actually, if you have a blunt tip, because that is what I'm seeing now in many cases, if you have a blunt tip, then it will not pierce the capsule, because many of times these capsules, they have a fibrosis and thicker at the center. So when you pierce, then it will tear if the tip is blunt. So tip has to be absolutely sharp and smooth and round. So these are the two important points which when you're using this device to prick the anterior capsule. Now, the important point is this actually technique, why I am stressing about this technique is it's very simple technique, very simple. See, you need just a saving needle, ₹1 saving needle, bend it and then prick it. Very simple, affordable, cost effective, just ₹1 device. You don't have to use that 5 crore femtosecond laser to create the capsular axis in this situation. You just use ₹1 needle to create the capsular axis. Very simple, it's affordable, very cheap, and it's repeatable. See, it's 100% successful. So that is the most important part. And third and the last important point is, even if you don't get the prick, even if you are not able to do anything on the capsule, but you will never land up with any kind of complication because of this prick. This prick will not lead any complication. Like puncture axis, I tried puncture axis or other techniques also, because puncture axis, once I went inside and the whole lens was out of the whole lens was out. Like out means like the whole zonules were broken because with the jerk. So this kind of problem will never happen with this technique. If you are not able to puncture, just leave it. You continue with your own technique. So that is the 3-4 advantages of this technique.
Right.
I think the basic difference is with the standard needle, we get a side cut, which causes extension and since it's producing no side cuts, it's a very smooth opening inside. So its extension is not possible in this case.
Yeah. So it works like a mini Rex, as we call it.
Yes.
Because we started
So
with
it's a sort of a small CCCC.
Yes.
Yeah.
And the second is someone has suggested instead of using Phaco Rexes, you can use vitreous cutter. Vitreous cutter, I have not tried it.
So that's it. Using vitreous cutter, using Phaco tape. Why not use 1 rupee needle?
Yeah, it's much cheaper.
It's
much
so
easier.
simple. And the second important thing is this puncturing the anterior capsule actually with this device. You can create a multiple puncture, because many times, as I said, you have multiple pockets. They don't get decompressed.
Right.
So you can create multiple puncture, which you cannot create with any other device. You can't do multiple puncture with the Phaco or multiple puncture with
I agree with Rajendra. When we have a simple device, why we should go ahead with other things? Because we have tried in thousands of cases. We can manage cases easily. When we have 2 rupee device, why should we go and take the unnecessary hazards?
Yeah.
Very right.
Welcome, Dr. Satanshu. Welcome. And now yours is the last talk, and we'll go ahead with the any other question, Dr. Arvind or Dr. Vinod?
Let me try first. Can I start sharing screen? Because let me try.
You share your screen now, and
I have internet problem. Otherwise, you will have to show it.
Yeah, Dr. Satanshu, you all know he's the one of the very dynamic person and multi-dimensional personality, because you have seen him in all the spheres of ophthalmology, all the spheres of the life. He's always there for anything, like you need any help, you need anything, and Dr. Satanshu is ready for everything.
Can you see my video?
Yes, welcome. Yes. And Dr. Satanshu is going to speak on approach to posterior polar cataract. Dr. Satanshu, now,
can you see my video?
Yeah, we can see now your presentation.
Good. Yesterday I could not start it. Thank you.
Yeah.
Thank you, Rajendra. It is always an honor to be part of your session course, because we learn a lot of things. So my topic is management of posterior polar cataract. So main thing in the posterior polar cataract is that if you take precautions and you are pretty aware that there is a chance of PC rupture in posterior polar cataract, you can achieve high success rate. What are the preliminary examination? Pre-operative examination. It is a one-like appearance. You can see easily on the slit lamp. You have to differentiate it with posterior subcapsular cataract. So if you are aware that there are chances of PC rupture, you will take all the precautions. You should know in 33% cases of posterior polar cataract, there are chances of posterior capsule defects. What are the precautions, the tips you should take? Number 1, capsular axis. It should be 5.5 or less, because in case of PC rupture, you can implant the lens over the anterior capsule. It should be not too small, not too large. No hydrodissection, otherwise it will increase posterior capsule descent. So hydrodissection should be avoided. In such cases, you see hydrodissection done, PC is ruptured. Number 3, whenever gentle hydrodilation can be done, because we are not doing hydrodissection, so we can do gentle hydrodilation from 2 sides. It should be complete. But all the procedures of hydrodilation should be very gentle. Epinuclear shell acts as a protective of the defective posterior capsule, so it should be removed in last. Because when we are doing Phaco, we are doing irrigation, it protects the capsule. You see, we have a large break in the posterior capsule. Before starting surgery, we know it. So we have to take all the precautions that this defect should not increase at any cost. Phaco is the safest option because chamber is closed all the time. This is the best technique in doing posterior polar cataract. Gentle hydrodissection done. We have not done any hydrodissection. Chopping is done, but we should not rotate the nucleus. Direct chop is preferred. We should not rotate the nucleus. By rotating the nucleus, we can increase the posterior capsule defect. All the manual should be gentle, as the rent is suspected behind. Parameter should be low, total height, phaco power, everything should be low. We have to bring all the nucleus part gently in the center, completely away from the posterior capsule in the pupil plane, and you should do phaco in the pupil plane, away from the posterior capsule. As the parameters are low, it takes some time. You should have patience doing the surgery. Instead of wasting time, if there is a PC rupture, you have to do vitrectomy. So instead, you waste time here. Have patience, go slowly, rather than wasting time in doing vitrectomy and everything later on. Epinuclear shell should be removed last because substitute for the posterior capsule. It is protecting the posterior capsule. So we are removing it in the last. We should not do any blind procedure. We should bring it into the center place, all the epinuclear piece, and gently we should remove it. As the parameters are low, it will take some time. Remember one thing, chamber should never be allowed to collapse. Whenever you remove the phaco, you should always inject viscoelastic from the side port so that chamber does not collapse. Collapse of the chamber will increase the posterior capsule end. IA should be very gentle. Bimanual is preferable in such cases. And we should do it from 2 ports. Posterior plaque is left to be removed in the last because there is no PC in the center in many of the 33% cases or many of the cases of posterior polar cataract. Again, see, whenever removing the IA port, inject Visco. We should never allow the chamber to collapse. Gently remove it. We can see this is the posterior capsular defect already there in the center and which was pre-existing. It has not increased even after the surgery. Can you see the pre-existing defect in the posterior capsule? It has not increased. There is no vitreous loss. No, this is the defect. So if you follow the 10 rules, correct preoperative diagnosis, shell, small but adequate axis, no hydrodissection, gentle hydrodelineation, no nucleus rotation, AC should be maintained every time, parameters should be low to total height, slow motion phaco, have patience, no panic. If there is a complication in PCR, you have to take care of it patiently. Rajendra?
Thank you. Thank you, Dr. Sudhanshu, for the excellent video on posterior polar cataract. And I think posterior polar cataract is one of the clinical situations, surgical situation we all come across, and we get in trouble many times because of its complexity, the posterior capsular opening up during the surgery itself, and getting into the problem of vitreous pronouns or the nucleus. But as Dr. Sudhanshu has described, if you take care properly from the beginning itself, before the surgery, your preoperative diagnosis, you have a posterior capsular opening or not, all these factors and the vacuum, your parameters, your phaco technique, and all these things would matter, because if you take care of all these 10 tips which Dr. Sudhanshu has given, you will definitely complete the surgery successfully, I think. And the most important point which I want to stress here is in posterior polar cataract is your hydrodissection, because there are a lot of discussion goes on. I'll ask the panelists also. Hydrodissection is one of the most important steps in posterior polar cataract, nothing else. But whether to do or not to do hydrodissection, that is one thing. If we have to do, what kind of hydrodissection we should do. Dr. Suven, your comments.
Yeah, I would generally tend to do a hydro-free dissection. So in that, what we do is basically take a spatula or a second instrument and under the capsular excess margin, sweep it all the way through one paracentesis. We sweep it for about 180 degrees or maybe a little more than that, and then through the other paracentesis again we sweep it under the capsule. So we kind of get the same cleavage. Now this does not serve the purpose of going beyond the equator. This is only till the equator, but this comes handy later on when you have finished your nucleus removal and you're removing the epinucleus. So the epinucleus anteriorly is now free from the capsule. So that's a huge advantage. And whenever you go later on, when you're confident that yes, you do not have a pre-existing PC rent, then it helps. If you do have to do a hydrodissection, there are situations when you might choose. Limited hydrodissection is one of the options, but then it becomes very risky how to titrate it, because you cannot really ensure that your limited hydrodissection is going to be restricted and not reach the posterior pole. So I would generally, if it's a classical posterior polar cataract, I would refrain from doing a hydrodissection. I would do a hydro-free dissection.
Right.
I agree with you, Praveen. In the case of posterior polar cataract, we should doubt there is a PC rent.
Absolutely, absolutely. If there is a PC rent, unless proven otherwise.
Dr. Vinod, your comment?
Dr. Satanshu has made it very clear. The most important point is keeping chamber maintained all the time. It should not go shallow. And of course, we can do oval axis in this case also, which helps us in chopping up. And if you want to fix a lens in the sulcus later on, so it gives a lot of space also. So oval axis is one of the choice, and keeping the chamber stable is second very important point. I think is the most important point. And third, the last piece we want to have, it's better to use a visco like viscotor or something, which keeps the chamber stable there. Even if you take out, rent will be there, it will not enlarge. I think these are very, very important tips.
There is a very easy way to make sure that your AC does not collapse while you are doing the last bit of epinuclear removal, is that you remove your side port instrument.
Yes.
Yeah.
You have only your phaco probe. There is no way you'll have surge. You go on to low parameters and just keep your phaco probe in, no side port instrument. You do not need a side port instrument for the epinucleus. It's not hard. It's going to just walk into and just use low. And if you can go into the epinucleus mode, which is basically a lot less energy, and it's got a vacuum arrangements to not cause surge. That would really ensure. And another point, I think we must resist that temptation to take out the small wisps of cortex from the posterior capsule, or attempt any form of polishing, even with the IA cannula. I mean, I dread to go anywhere close to the central posterior capsule in a posterior polar cataract. I will deal with that in the post-op period. I can do a YAG cap as early as is required, but I would rather not have a PC rent on the table.
Yeah. Dr.
Second thing, do you have any experience of doing posterior polar cataract with the infusion cannula at the 6 o'clock position?
No problem. No, I couldn't hear.
Do you have any experience of doing posterior polar cataract, or you would like to do with a IV cannula at the 6 o'clock piece, infusion cannula?
I'm using AC maintainer for that purpose.
I am talking about AC maintainer, because this is another good option to avoid the chamber to collapse. We can use the AC maintainer.
Yeah, and as Dr. Satanshu has very nicely described the last step, because the posterior polar plate, which is stuck on the posterior capsule, because you have to make sure like whether your plaque is stuck on the posterior capsule or no. If it is stuck, if there is adhesion of the posterior polar cataract with the posterior capsule, in that situation you have to leave that plaque for the last. He has very clearly shown it, very nicely shown, Dr. Satanshu said, like you leave the plaque for the last. You remove the cortex, you remove the epinucleus, and we call it as a partial segmentation of the epinucleus. Like you hold the epinucleus from the periphery, start sucking and go towards the center, but break it off at least 3 millimeters away from the center. And like this, you just go all around, you completely suck out the epinucleus, leave that center plaque for the last. So once everything is clear, then you hold the center plaque. You can hold it with the aspiration cannula, or you can hold with the forceps also, plain forceps. Then you can dissect it and take it out. that is one very important point. And second, which I was asking about the hydrodissection, because hydrodissection is also very important step in posterior polar cataract. What happens actually, if you don't do the good hydrodissection, then taking out the cortex away from that plaque area becomes very difficult. Then you hold it and you try to put a stress on the posterior capsule, you may rupture the posterior capsule. So as Dr. Suven has said, like he preferred to do the hydrodissection up to the equator. This is called as a multi-quadrant hydrodissection, multi-quadrant partial hydrodissection. You inject the fluid at the multi-quadrant, but the fluid wave should not go posteriorly towards the posterior plaque. It should go up to the equator or little away from the equator, but it should not go, the wave should not go through and through. So that is important, because you have to, in any case, like do a little bit of hydrodissection so that it becomes easy later on for the removal of the cortex.
Rajendra, for this we are using a cannula now, which is blunt from the tip, and there is a side port, and there are two side ports. So when we do hydrodissection, the fluid does not go behind the nucleus, it goes on the side. So this cannula is helping us, but we have not made a video of this cannula. We are going to do it for the next time.
Okay.
This cannula is helping us because the fluid is not going behind, because the tip is blunt. On the side they are whole, fluid is going on the side of the nucleus.
Right. It's not
while we are on the topic of posterior polar cataract, there is an interesting thing which happens often to all of us, and maybe our younger colleagues over here would benefit, would probably also know. We have this something called the cookie cutter defect. In a posterior polar cataract, often when you suddenly find that in the epinucleus or the that centrally there's a clearing and your heart is in your mouth, you think that the posterior capsule is gone.
Yeah.
So and then you are kind of tentative. You don't know. You're not sure whether it's the PC is intact or it's gone, and that's a very sharp cut kind of cookie cutter. So the easiest way to differentiate is just hang on over there and take out your instruments after injecting viscoelastic. And as you inject viscoelastic, if that size of that so-called cookie cutter defect does not increase, you have your PC is intact. If the size increases or which just messes around a little bit, you know you've done the damage. Yes. So that's, I think, a very important differentiate.
I think in posterior polar cataract, if you are not getting a hole even, still the posterior surface of the capsule is very, very weak.
Yes.
So one has to be very careful not to polish that part. That's very, very important. I think that's a very important tip for them.
Already, Suben has said it is better to do the yak authority later on rather than to test the PCR in the table.
True. So
I think we are doing good on time.
Yeah.
Thank you, Rajendra, for inviting us for this wonderful IC. Always you have, we learn a lot from you, new technique, innovation. Suben, thank you very much.
Yes, thank you, Sudhanshu. Thank you, Dr. Vinod. Thank you, Dr. RP.
Now, Vinod and we used to keep talking.
Thank you, Suben, Dr. Arora, and Dr. Sudhanshu. Really.
Yes.
Thank you, sir.
Thank you
for the opportunity.
Arvind,
thank you. I can't see Arvind.
Arvind, where you are? I can't see you.
Next, actually, he has next IC now.
Okay, yes. I think people are very busy. The virtual conference has been busier than the real physical one.
Rajendra, normally when we have last session, the last day, we used to be annoyed. But now it is very good to have a live session last day, because Sunday, people are in the afternoon. Sunday, because they are at home, they work in the morning.
Sunday is the prime day. You get the maximum attendance. Most of the
because I used to normally I used to get last session or last day, but I was very annoyed. But today, now I got the first session of the first day. Then we very problem with me.
I was told by the operators that we have around 250 people watching the session.
Good.
That's a very big number in this day, because today is Sunday.
Yeah, there is plus there's a quiz I think going on. A quiz will be starting very soon, and there are other important sessions, very interesting sessions also going on.
Yeah. Good. Thank you very much.
Thank you very much. Thank you.
Thank you, everyone. Thank you. See you next year.
Thank you.
Thank you.